Hi there, my name's Tim Walker. I'm one of the anaesthetists in Bristol at Southmead Hospital, and today I'm going to present to you a little bit about obstetric analgesia and anaesthesia for midwives. I'd like to thank Ed Miles, who's one of the senior trainees in anaesthesia in Bristol, who did this presentation previously. This is a new presentation, but I've amalgamated quite a lot of stuff, including slides and content that he has previously used. So thank you, Ed. So the aim of this session is to explore the various techniques employed by midwives and anaesthetists on delivery suite and elsewhere to manage pain in peripartum women. So hopefully at the end of this session you'll have a greater understanding and be able to support women in their choice of analgesia, and in the more anaesthetic related areas have a little bit better understanding of how to manage a woman with an epidural or a PCA, and women who will have spinal anaesthetics or general anaesthetics. So to begin with, in the first part we'll look at different methods of analgesia, i.e. pain relief, in the simpler form that doesn't involve necessarily anaesthetic involvement, and then we'll go on to look at anaesthetic related issues regarding pain relief and management. So why don't we first start by thinking about what actually is pain? Well, we have a definition. So pain can be described as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So we could ask, why do we want to manage pain in labour? Isn't pain in labour a natural part of childbirth? And although this is true, how women experience pain during their labour and post-delivery will inform their overall well-being as regards their birthing experience, obviously their recovery from having a baby, and may have longer-term effects on their mental health and well-being and their plans for future babies. So it is worth addressing. It's not something that is just about relieving pain. It contributes to their whole birthing experience and their experience of pregnancy, and informs their well-being in the longer term. So in first thinking about pain, we're going to watch a little video, a TED video called "This Is Your Brain on Pain," which will give you some little background to how pain is transmitted and perceived, and why people may vary in their experience of pain.
Let's say that it would take you 10 minutes to solve this puzzle. How long would it take if you received constant electric shocks to your hands? Longer, right? Because the pain would distract you from the task. Well, maybe not. It depends on how you handle pain. Some people are distracted by pain. It takes them longer to complete a task, and they do it less well. Other people use tasks to distract themselves from pain, and those people actually do the task faster and better when they're in pain than when they're not. Some people can just send their mind a-wandering to distract themselves from pain. How can different people be subjected to the exact same painful stimulus and yet experience the pain so differently? And why does this matter? First of all, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is something we experience, so it's best measured by what you say it is. Pain has an intensity. You can describe it on a scale from 0, no pain, to 10, the most pain imaginable. But pain also has a character, like sharp, dull, burning, or aching. What exactly creates these perceptions of pain? Well, When you get hurt, special tissue damage sensing nerve cells, called nociceptors, fire and send signals to the spinal cord and then up to the brain. Processing work gets done by cells called neurons and glia. This is your gray matter. And brain superhighways carry information as electrical impulses from one area to another. This is your white matter. The superhighway that carries pain information from the spinal cord to the brain is our sensing pathway that ends in the cortex, the part of the brain that decides what to do with the pain signal. Another system of interconnected brain cells called the salience network decides what to pay attention to. Since pain can have serious consequences, the pain signal immediately activates the salience network. Now you're paying attention. The brain also responds to the pain and has to cope with these pain signals. So motor pathways are activated to take your hand off a hot stove, for example. But modulation networks are also activated that deliver endorphins and enkephalins, chemicals released when you're in pain or during extreme exercise, creating the runner's high. These chemical systems help regulate and reduce pain. All these networks and pathways work together to create your pain experience, to prevent further tissue damage, and help you to cope with pain. This system is similar for everyone, but the sensitivity and efficacy of these brain circuits determines how much you feel and cope with pain. This is why some people have greater pain than others, and why some develop chronic pain that does not respond to treatment, while others respond well. Variability in pain sensitivities is not so different than all kinds of variability in responses to other stimuli, like how some people love roller coasters, but other people suffer from terrible motion sickness. Why does it matter that there is variability in our pain brain circuits? Well, there are many treatments for pain, targeting different systems. For mild pain, non-prescription medications can act on cells where the pain signals start. Other stronger pain medicines and anesthetics work by reducing the activity in pain sensing circuits, or boosting our coping system, or endorphins. Some people can cope with pain using methods that involve distraction, relaxation, meditation, yoga, or strategies that can be taught like cognitive behavioral therapy. For some people who suffer from severe chronic pain, that is, pain that doesn't go away months after their injury should have healed, none of the regular treatments work. Traditionally, medical science has been about testing treatments on large groups to determine what would help a majority of patients. But this has usually left out some who didn't benefit from the treatment or experienced side effects. Now, new treatments that directly stimulate or block certain pain-sensing, attention, or modulation networks are being developed, along with ways to tailor them to individual patients, using tools like magnetic resonance imaging to map brain pathways. Figuring out how your brain responds to pain is the key to finding the best treatment for you. That's true personalized medicine.
So I suppose one of the take-home messages of that video was that we all perceive, respond and cope with pain stimuli in differing ways, and there's different modalities that can be used to treat pain, limit pain, and we have to bear this in mind when we're dealing with an individual patient. So we're going to look at some of the methods of pain management in labour. So first of all, we can consider some of the non-pharmacological approaches to improving patient experience of pain when they're labouring. And some of these will be simply environmental, so the place they're in whilst they're labouring, the positions they are able or not able to get in during labour, the environment in terms of lighting, in terms of temperature, all these issues that may help them relax, going in the pool. Increasingly, hypnobirthing type techniques are being adapted, and it's quite I'm sure you'll know, a lot of couples come with having done a lot of thinking about both the environment and the words that they'd like to hear during their labour, and this will all be individual as to what they feel will help them, what won't help them, and what's on the birth plan may actually not turn out to help them that much. And we always have to think about them being flexible in terms of what they feel they might need, what might benefit, and be ready to adapt for a changing situation in regards to their pain. Aromatherapy, that's increasingly used on birthing units and on delivery suites. Acupuncture, less so because of the practicalities and the few practitioners. TENS is basically a kind of form of acupuncture in some ways, so that's very popular. So all these non-pill, non-anaesthetic approaches are always ones we think about, especially in latent phase and in early labour. So just in regards to TENS, just to summarise what it is, so it's transcutaneous electrical nerve stimulation, and hopefully you've all seen them. They're small battery operated devices with sticky pads that normally go on the woman's back, and they transmit impulses, electrical impulses, which may reduce the pain signals going to the spinal cord and hence to the brain. There's also some potential evidence that they stimulate endorphin release in the brain. There's no great definitive studies on TENS. Some women find it very helpful, some really don't. So it's variable outcomes. Acupuncture, although it involves tiny little needles, is similar in principle to TENS. It's stimulus modulating pain signals. Again, not so commonly practiced because it's just practically more difficult in labour to be doing that kind of thing. Aromatherapy, again, it's sending signals to the brain, but in terms of a chemical signature. The evidence is mixed. Again, some women find it very helpful, especially in latent phase or early established labour. We do have to be a little bit cautious in terms of its use, and most units will not use aromatherapy below 37 weeks gestation because of potential harm to baby. And we also have to be cautious for maternal reasons in patients with raised blood pressure, diabetes, epilepsy, and any women with notable allergies. So it's not one we normally put the sign up on the door that it's being used, and it is not without risk to both those in the room and those coming into the room. So it's worth putting up the sign for that. And obviously Entonox, gas and air, commonest kind of thing that you'll see, especially on a labour ward. So gas and air is effectively a 50-50 mix of nitrous oxide and oxygen. So nitrous oxide is a good analgesic gas with a long history of use in anaesthesia. You can't put someone off to sleep with nitrous oxide alone, but it's always been considered a very good analgesic gas in anaesthesia, though its use is actually relatively minor now in general anaesthetics. The reason we mix it with oxygen is just to prevent any patient hypoxia, because it's 50% nitrous to provide the analgesic effect. But if you mixed it with air, then you're potentially giving patients less than their 21% oxygen they breathe on room air. So we mix it with oxygen, and as you know, it's some women find it wonderful and get high as a kite, but really does help their pain. And some women, it just makes them feel sick, or they don't like the experience of feeling disinhibited or a little bit high with the gas, and so even though they're struggling with pain, they don't find it beneficial. So we move on to pharmacological analgesia. So simple analgesics such as paracetamol, which sometimes gets underrated. It's an over-the-counter tablet that we all have taken, but it's safe. It is effective. We tend to avoid non-steroidal drugs such as typically ibuprofen or diclofenac in antenatal women. We tend to save them for postnatal women as part of pain relief. And the risks with giving it when baby's still inside is potentially small risk of early closure of one of the blood vessels, the PFO, in the fetal heart, potential risks to baby and other organ damage, and obviously we tend to avoid them in mums anyway that might have preeclampsia or known other kidney or gastrointestinal disease. We give opioid analgesics, so morphine type of analgesics. Commonest one we tend to give at Southmead, because there's been some controversy over codeine-based pills, is we give dihydrocodeine. There's no evidence that it does harm to mum or baby in terms of breastfeeding or the GI tract of baby. So we give that, and that's very useful again in latent phase or even in early established labour. And obviously pethidine is one that's been used in labouring women for many years and in latent phase, in combination with Phenergan, which is a kind of slightly sedative anti-sickness injection. They tend to work very well together, and pethidine is obviously used throughout latent phase and established labour, unless we think we've got a very prem baby or we're soon near to delivery. So now we'll move on to more advanced techniques of pain relief, which tend to involve anaesthetic input. So patient-controlled epidural analgesia, or PCEA, and intravenous pain relief, patient-controlled analgesia, PCA. So regional anaesthesia in obstetrics. So why do we use it? So the indications are obviously pain relief during labour, analgesia. We use regional anaesthesia for caesarean sections mostly. Rarely do general anaesthetics. And other cases where women need to go to theatre, so instrumental deliveries, forceps deliveries, postnatally where they develop third or fourth degree tears, and it's difficult, if not impossible, to comfortably repair those without a spinal epidural anaesthetic. Manual removal of placenta, again, which is very stimulating and uncomfortable without regional anaesthesia. Patients antenatally who've got threatened preterm labour may require cervical suture, normally done under a spinal block. Situations such as EUA, so examination under anaesthesia, for example in significant postpartum hemorrhage, where the obstetricians need to be able to have the patient extremely comfortable to assess and address the cause of PPH. And we also have relative indications for regional anaesthesia, where we would say recommend an epidural. We certainly do in women having vaginal twin delivery, where an early epidural is considered safest in case twin 2 becomes distressed. We've got a good working epidural. If we had to rush to theatre, then we've got that as something we can easily top up. Preeclampsia we often recommend in partly to manage blood pressure, partly to limit the stress of labour, And similarly, if a woman has significant cardiovascular disease or even neurological disease or any other condition where we would feel that we would like to reduce the stress of labour, then we may be recommending an epidural early on in labour. Also, where women have SPD, or it's more commonly known PGP, pelvic girdle pain, where they're going to struggle to labour without regional anaesthesia or vaginismus, where they'll struggle to be examined. So regional anaesthesia has a place just beyond patient preference. Obviously, it's some areas where we can recommend its use, not just for reasons beyond just simple improving pain relief. So it's worth covering where we contraindicated for regional anaesthesia in obstetrics. So whether or not we feel it's in mum's best interest to have a spinal epidural, patient refuses, obviously she shouldn't have one. Where there's severe maternal hemorrhage or hypovolemic shock, regional anaesthesia is potentially very dangerous and can contribute to that further. Where the patient has raised intracranial pressure, the potential for neurological damage with regional anaesthesia. In coagulopathy, so normally inherited or acquired conditions where mum's blood clots either too well or too poorly, they might be on Clexane, and we have to time regional anaesthesia around Clexane doses, varyingly on whether it's prophylactic or treatment dose. So there's certain situations where it's dangerous to stop Clexane because of a coagulopathy in mum or high risk of thromboembolic problems. So regional anaesthesia may not be an option. Where it is an option, we have to time when we stop Clexane or when the last dose was. So we don't do regional anaesthesia within 12 hours of a prophylactic dose of Clexane. And if they're on treatment dose Clexane, we should wait 24 hours after that last dose before putting needles in their back. Aspirin, which a lot of women are on antenatally these days, not really an issue, and it shouldn't preclude regional anaesthesia. And there's some relative contraindications to regional anaesthesia, where a patient is bacteremic or septic, potentially a spinal, more worryingly, say an epidural catheter could be a secondary potential source of infection, being a foreign body. We tend to have quite a high threshold for that to be a contraindication, to be fair, in obstetric patients. There's relative contraindications where patients have neurological lumbosacral disease, where they've had surgery, especially on their back. We have to review that from patient to patient. It will be a risk versus benefits, and it will vary from patient to patient, not only to how safe doing a regional anaesthetic in the back is, but also the likelihood of successful epidural or spinal block. And normally we will see these patients in their antenatal period and formally discuss with them what the anaesthetic plan would be as regards regional anaesthesia during their labour. In preeclampsia, or there's potential obviously for the platelets to drop and be low because of the preeclampsia, and some other women will have thrombocytopenia or low platelets for other reasons. We have no absolute limits. Again, it's a risks versus benefits scenario, but generally epidurals, most anaesthetists will not be comfortable putting an epidural in unless the patient's platelet count and a recent platelet count is over 100, and spinal needle, which is a smaller needle, we still prefer the platelets mostly over 50. But I say this is always assessed on a case-by-case basis to a degree, and in preeclampsia we may be more risk adverse to an epidural if serial blood tests show the platelet count dropping quickly, where we have to potentially assume that the patient is at higher risk of having bleeding when we put an epidural needle near to their spine. Maternal cardiovascular disease, it's a little bit more advanced. We encourage regional anaesthesia in mitral stenotic disease, but we don't encourage it in aortic stenosis or pulmonary hypertension. And where there's a woman's had previously difficult or complicated regional anaesthesia, especially if she's developed side effects or long-term complications, will again need to assess the risk of further regional anaesthesia during her labour and delivery. So when these patients with these kind of stories pitch up, it's best if we identify them and review them in the antenatal period rather than when they walk through the door in labour. Where women can't have regional anaesthesia, where we consider it is unsafe, then remifentanil PCA is an alternative to regional anaesthesia in labour. So remifentanil is a very potent form of morphine, very potent but very short acting, and can be delivered intravenously with a patient-controlled analgesia button. The evidence around its success is mixed, but where a woman absolutely can't have an epidural or a spinal block, well, certainly an epidural for labour, then remifentanil PCA is one of our considerations. So when it comes to regional anaesthesia, if we just look at some stats from my hospital, Southmead, this goes back a few years. But as you'll see, we're going to do quite a lot of regional anaesthesia. So our caesarean section rate a few years ago was 28%, and that's combined primates and multips. And it's actually, like most places in England, certainly, and probably all the UK, our caesarean section rate tends to have risen a little bit since then. Our epidural rate, so about a third of primates will have an epidural, and still a significant number of multips, so less common, but a few years back it was 12.2%. I suspect it might be a little bit higher now. And if they have a epidural, the mode of delivery, so about a third will have a normal vaginal delivery with an epidural, a third will have assisted delivery that will either be instrumental device in the room or in theatre, and just under a third or so will have an emergency caesarean who have an epidural. So, and it's a little bit more common for primates with an epidural to have a caesarean, about a third of them, than multips with an epidural. So about 1 in 5 with multips. So let's discuss epidural analgesia. Well, it's the commonest form of regional anaesthesia in labour. When do we offer, or is it asked for? So it's normally asked for in early-ish labour in primates, later labour in multips, where often it's too late. But it's often asked for or requested when after non-regional anaesthesia has been tried. So after they've had their pethidine and phenergan in latent phase, and then they go into established labour after they've been on gas and air, but still struggling, or their TENS machine. So when it's normally considered when other forms of pain relief have been proved insufficient, though many women now in their birth plan will express a desire for an early epidural, or they will certainly feel that that is their go-to, as opposed to they don't want pethidine. They don't really want to try TENS. They'll try gas and air, but actually they've got their mind set on an epidural once they're in established labour. There is an issue of informed consent about epidurals. We do encourage units and midwives to try and give pre-labour information about the benefits and risks of an epidural, though mostly the epidural information card is read by women or by their partners to them in labour. And we do this as a verbal consent procedure, but it is important, as those Southmead midwives who know me, that it is important that there is some form of information given and received. So I'm very hot on that they have definitely read or heard the epidural information card, so they are technically aware of the risks. They say, I think if we encourage pre-labour information on regional anaesthesia, that would be preferable, because the time to make an informed decision on pain relief is not necessarily when you're sucking on the gas and air and really struggling with pain. However, some women will come into their labour with the preference that they definitely don't want an epidural, and I've seen this many times, and it's on their birth plan. And of course, they're allowed to change their mind if they feel that they can't cope without one or they'd like to try one. So, and they're allowed to request one at any time. The timing of a good, successful epidural varies from patient to patient, but generally late in phases, not always a great time to put it in, or pre-ARM, but we judge everything on an individual basis in discussion with the patient and midwife and obstetricians. So what is an epidural? So we're going to just do a few little slides on the anatomy and the pharmacology. So I'll let you study this little slide for a minute. So as you can see on the picture, that's the spine. You've got the spinal cord. Where we tend to go for an epidural, we're actually going below the level the spinal cord technically ends, and we're trying to, so we go about L2, 3, 4 level. So we're not where the true cord is, but we're going in a level into the epidural space, where nerves come off the spinal cord. So we're aiming, as you can see with that needle, we're going through the patient's skin, and then we're going through between the spinous processes, and we're going into the epidural space, and we go through a ligament, a tough ligament called the ligamentum flavum, and then when we're through there, we're into the epidural space, which is a potential space. Doesn't normally have anything running through it except some few blood vessels and nerves, and we're feeding a little plastic tube, the catheter, into that epidural space, and then we give the anaesthetic through there. If you see that just beyond the epidural space is the dura, so the dura is the lining over the spinal fluid canal, so we're very close to that, and that's why potentially the needle can go too far and make a hole in the dura, which could cause a spinal fluid leak, which we'll come on to later. Just in basic bit of terms, so epi means above, so it's above the epidural space. The dura is the fibrous membrane surrounding the spinal cord, and it contains CSF, so cerebral spinal fluid, and that bathes the spinal cord, and it's a column of fluid bathing the spinal cord and the brain. And if we zoom in on that slide there, you see the epidural needle going through the back, into the epidural space, and the little blue thing, little plastic epidural catheter that's being fed into the epidural space, and we feed it so it goes upwards. There's a little bevel on the end of the needle that sort of feeds it in that direction, and then we put the anaesthetic through there. So a little bit on the pharmacology of what we actually put in the epidurals. So it's actually normally a combination of a weak local anaesthetic solution combined with an opioid, so a morphine-like drug, to enhance the pain-killing action, and also the opioid, in this case fentanyl, which is the commonest one that will be in this mix, prolongs the action of the epidural solution. So bupivacaine is like the same kind of local anaesthetic as lignocaine. Lignocaine's very fast onset, shortish duration. Bupivacaine's medium onset, slightly longer duration. But it's actually, we put it in a very weak solution, so it's only about 0.1% or 0.125% in the picture there. It's 1 milligram per mil. So if you think your 1% lignocaine is 10 milligrams per mil, so it's not a lot, and 2 micrograms per mil of fentanyl. That's not a lot of fentanyl, but say in the mix where it goes, it has a more profound effect than if it was going intravenously, which hopefully it shouldn't. So it's relatively weak solution is the upshot in terms of the actual amount of drug in there, but where it goes in the epidural spaces where it has the more profound effect. And so in a patient-controlled epidural, so PCEA, the woman controls her own dosing of the anaesthetic, and it's based on her own experience of pain in labour. So we give the initial bolus to get her comfortable, and then we let the woman be in control of topping up her pain relief. So hopefully you've all seen a epidural being put in, or you soon will. So the technique is a full aseptic technique. So we use 0.5% chlorhexidine washed to clean the skin, and the anaesthetist should be fully gowned, gloved, and masked up, even in non-COVID times. So we should be fully aseptic to do this. The patient should either be sitting or in a lateral position to have the epidural insertion. We tend to try and probably most epidurals are done sitting up because it's a little bit more technically easy for the anaesthetist, especially in raised BMI patients, because the anatomy is a little bit more straightforward and the approach. But increasingly we try to offer lateral, say where the woman feels that she would struggle to sit up, and actually because sighting epidurals is all about being in the correct position and compliant in terms of staying still. If it's an easy spine and they're going to struggle to sit up but they're quite good in lateral position, then we should try and give that patient that choice. So as I said, common levels of insertion, we either pop it in at L2-3, L3-4 in the lumbar spine. We put local anaesthetic in at the skin to numb things up for the epidural needle. The epidural needle is about 16 gauge usually, and it's a biggish needle, same as your grey Venflon. So we put in a good 5 to 10 mils. I tend to always give at least 10 mils to numb up the skin with some lignocaine. And then we use a loss of resistance technique. So we most commonly will fill our special blue loss of resistance syringe with saline. Sometimes people will use air, but the principle is that when we go into the epidural space, we're going through skin, tissue, fat, and this tough ligament and flavum. Now, the epidural space doesn't normally have anything in it. It's a potential space. So when we get into it, our loss of resistance syringe the plunger should pop down. So we suddenly get loss of resistance. We know that we're going into the epidural space, and we're putting, it's quite safe. We're just putting saline in there. So how deep do we go? Well, we normally find that the epidural space in most patients lies around 4.5 centimetres average, but that can vary depending on the body habitus of the patient and just natural variation. So it can be as shallow as 3 centimetres in larger patients with perhaps more subcutaneous fat, or if we have to angle the needle to get between, upwards, or creating a longer distance to get where we need to go, it can be 7, 8 centimetres or more. I think the deepest space I've had is 11.5 or 12 centimetres. We have a longer epidural needle should we need it. So once we get in the epidural space, then we insert that little plastic catheter, which has got little holes on the end of it coming outside the anaesthetic, sprays out the end. And we tend to leave about 4 to 5 centimetres of the epidural catheter in the space. Any more, and sometimes it's more got potential to curl up in the space and perhaps block one side better than the other. Any less, and then if the epidural moves, the anaesthetic might not spread out the end of the epidural as well. And if it moves backwards, we might come out the space completely. So it's a little balance to be drawn there. The little plastic tube epidural catheter has got markings on it so we can tell how deep things are. When we get in with the catheter, we sort of do a few little checks. We check we can't see spinal fluid, and a meniscal drop test, because the epidural space isn't filled with anything. If you see the anaesthetist holding a little plastic tube up in the air and watching it, it's because he's watching fluid drop down the catheter. That indicates that it's not meeting any resistance, so it's filling into the epidural space, which necessarily normally doesn't have anything in it. So that's a nice little indicator you're in the right place. We give a test dose of the anaesthetic initially, just to check. We give it a few minutes to check that it's not going where it shouldn't, so it's not going into the spinal fluid, it's not going intravenously. Then we securely place it, so lots of taping down, and various anaesthetists have different techniques to how they want to tape the epidural catheter. We tend to leave a window over the clear dressing where the non-see-through tape goes around, so we can see where the little tube goes directly into the back to see if it's moved or not. Intravenous access is always a prerequisite, so epidural is a potentially serious procedure in terms of adverse events, so we need intravenous access before we do an epidural. And in the old days, we used to fluid load patients, and sometimes we still do. We always run IV fluids pretty much with an epidural, because the potential is that the epidural anaesthetic can drop the blood pressure, because it has an effect on the blood vessels below the level of the epidural, below the level of the block. So it can cause vasodilatation, which can drop the patient's blood pressure. So to compensate, we often load them up with fluid, or we certainly keep them on some fluid. And we do regular blood pressure monitoring throughout management of an epidural. So we mentioned the commonest injection mix, and most units I think around the country will use this is sort of 0.1% bupivacaine, which is an amino amide local anaesthetic, and 2 mics per mil of fentanyl, so commonly known as ready mix. They're not technically called that necessarily. So initially, the anaesthetist will give probably 15 to 20 mils to get on top of pain. So perhaps 10 mils test dose, 10 mils main dose, interspaced by a few minutes to check for any adverse reaction. But again, varies from anaesthetist to anaesthetist slightly, but that's the common kind of volume for initial dose, which will then probably keep the patient comfortable for an hour or so at least. Then we'll give them the button, set up the button, and they can press and give their own pain relief. Always worth noting, it should say on the epidural information card, but always remind your patient and their partner that an epidural is not an instant result. It normally takes 20 to 25 minutes, sometimes a little bit longer to have a really full effect. What they tend to notice is in the first 5-10 minutes, though, after the anaesthetic has been given, that the contractions start to seem shorter and less intense. So increasingly now it's just feeling the peak of the contractions. Then hopefully in 20-30 minutes, at most, they might lose awareness completely of the contraction, but more commonly they'll be aware of tightness, but not pain, and it will be short-lived. And they'll get off the gas and air, and they'll look very calm and happy, and often fall asleep. Alternative mixes, so if the epidural is not completely perfect, sometimes your anaesthetist will give additional boluses of slightly stronger bupivacaine, so 0.25%. Sometimes we stick a bit more fentanyl in. And occasionally where patients are very sensitive to and we know they're sensitive to the fentanyl, so a little morphine drug, although it's at very low dose, if people are very sensitive to that kind of thing, they can get quite bad itching. So the alternative then is to run an epidural anaesthetic without any fentanyl in, which will work, but perhaps they'll need more anaesthetic to keep them comfy. So we can just run plain 0.1% bupivacaine without the fentanyl. When we take them to theatre for a cesarean or an instrumental delivery, we need them a lot more numb than just pain relief for labour. So we need a more profound block, often higher and more intense. So at Southmead and in most of Bristol, we use something called 2% physilignocaine, so rapid onset of high concentration lignocaine that's had its pH altered by sodium bicarbonate. That's why we call it fizzy, though it doesn't really look fizzy. But it's a rapid onset of a profound block, so it's really good in those emergency cesarean sections to get them very numb for a section with their epidural. In the old days and in other places around the country, they might just use stronger bupivacaine, so 0.5%, which can take a little bit longer to achieve your block. We use preservative-free preparation to avoid neurovascular damage in all our epidural anaesthetics and spinal anaesthetics. And on our PCEAs, I think it's a fairly standard regime for places that use them. So after the initial 20 mils, whatever we give the patient, then when they come to use it themselves, every time they press the button, they'll give about an 8 mil bolus. And then once they've given a dose, then even if they press the button again, it won't give another dose for 15 minutes. So there's a little safety lockout period. So here's a little picture of at Southmead how your tray that you'll take in to set up your epidural. So it doesn't have the drugs in there, but you've got normally a pre-packed epidural pack with all the needle and all the stuff in there, the cleaning solution. So you need stuff to clean the back and stuff to clean the anaesthetist's hands, bits of tape to stick things down, etc. So on the next slide or next video, we're going to just see an epidural being put in and someone very nice and friendly discussing how it's done and why it's done. So enjoy watching that. So, hope you loved that. That was great, wasn't it? Very professional. Um, so, the kit, the epidural pump. So, these are fairly common, these ones. You might have slight variations around the country, but this is a pre-purposed epidural pump. So, it's a machine. There's a box there to lock your anaesthetic in, because remember it's got fentanyl in, so technically it is a controlled drug. So these pods, as we call them, the bags of fluid, should be kept in a controlled drugs cupboard, and when they're in use, that it should be set up by the anaesthetist, this thing, and it should be locked. So there's a little lock on the door there, so it can't be nicked. So the epidural pump is set up by the anaesthetist. On maternity units, these pumps can be programmed for various types of situations involving an epidural. They can be programmed for continuous infusions or different dosages. So the anaesthetist should check, but mostly the pumps that we'll use in labour ward will be, a default program will be for a obstetric anaesthetic. So the 8 ml bolus, 15-minute lockout, we check that when we set it up and approve the program. So you get 250 ml pre-filled pod or bag. Sometimes they come in 500 mils, big ones. That's pretty much normally, it takes a lot to get through more than one of those in a labour. So normally, once that thing's in, that will last a patient till delivery. The anaesthetist should have a lock for the box. One of the midwives should have one as well for disposing of the non-used anaesthetic. There's an air filter on the line, which you can't see here, but when the anaesthetist connects all this up to the patient, but the round bit is an air filter and bug filter, and the pump has things to detect air or occlusions. It's important to connect these pumps, plug these pumps into the wall, because you're going to be, when you're assessing and managing an epidural, looking at, you'll be looking at the history, and it will tell you how many times the patient's tried to press the button, how many times it's been delivered, how much anaesthetic they've used. If the pump runs down, the battery will go, you'll lose that program and you'll lose the history. And often these pumps are not, when they're sort of not in use, they're not normally plugged in. So you need to be mindful of trying to plug them in when you're actually going to use them with a patient, because you don't really want to lose your program and your history of delivery, because it will make your records a little bit more difficult. So this is typical of the documentation that we use at Southmead. So this is our anaesthetic chart at Southmead for obstetrics. It varies from our normal anaesthetic chart, so it's specifically for obstetric anaesthetics, and this should be filled in. This bit should be filled in by the anaesthetist. So we'll write a little history and just document them. So patient's got informed consent, and various other bits and pieces. And then we'll record on this chart the details of the insertion, depth of the epidural space, etc., etc. And this will be used for epidurals or spinals, and our initial doses. And at the bottom, not necessarily for us, but for you midwives, so when the epidural comes out, when it's not needed anymore, it's important to document the time and date, and that the little blue tip at the end of the catheter was seen when it was taken out, and it was all intact, and none had sheared off and left in the patient's back. And the other side of the chart on here, so this is recording at the top dosages and blood pressures, the initial kind of doses. And there's a few more columns to that, because often we give an initial dose, but the anaesthetist might need to give supplemental or stronger doses, and we might want to do a whole new set of blood pressures. So we tend to do like 6 blood pressures initially after insertion for the first half hour, because that's when probably, if the epidural is going to affect the blood pressure it's most significantly, it'll probably be in the first hour after the first top up.
But say if we give stronger top-ups later on, we need to have another half hour's worth of recordings. And then the bottom half of that is what midwives fill in. So it's documenting blood pressure every hour or so, their respiratory rate, pain score, is it working? And then we get them to use ethyl chloride, so the cold spray, to assess the levels of the block in terms of dermatomes. And then on the right, there's helpful kind of dermatome charts, so to aid midwives to say where the block is and where they're not cold and when they are cold. And also we document how many times the woman's pressed the button and given a dose, and what volume's left, what volume's gone in the bottom right, there's some alternative prescriptions, but to be honest, we tend to just let them run on the PCA prescription. We don't tend to put other stuff down these days, but there will be occasions where that's handy. And here's an example of an epidural information card for the patient, just laminated card that we sort of keep in all our labour rooms. It's the information source from the labourpains.com site, but it gives all the standard risks, which we'll come and discuss in a sec. I say it is important, certainly for me, that to know that the patient or has either read the card herself or the partner has read it too, or the midwife, just so that we can say yes, well, there has been informed consent of to some degree before we do this procedure, because it is potentially risky. So, going on to the risks associated with epidural. So, here's a risk that it might just not work very well. So, there's some factors for that. About 1 in 8 won't be completely brilliant and perfect for labour. They might be not work at all. They might be a bit of a patchy block. Sometimes that's affected by position of baby. It's harder to block baby pains from labour if they're OP. Often they get sacral sparing. They're less likely to work or need reciting if they've got significantly raised BMI. Part of that is it's technically more difficult to put them in sometimes. Partly we think they're increased risk of the catheter migrating or the anaesthetic not spreading well. And similarly in severe scoliosis or lumbosacral disease, there's, especially where they've had surgery, there's more risk of them being technically difficult to put in and the anaesthetic not working and spreading as well. And about 1 in 20 of them won't be effective when you top the strong stuff if you need to do a cesarean. And you have to consider a spinal block as an alternative in theatre or even a general anaesthetic. So the epidural headache thing, so that's a dural puncture leading to a headache. So where the needle goes a little bit too far, hits the spinal fluid canal and causes a spinal fluid leak. That happens roughly about 1 in 100 of all epidural insertions. And where that happens, so about 70% where we've caused a hole in the spinal fluid canal and caused a leak, that will lead to a headache. Some of them will heal up by themselves and not get a significant leak, but about 70% at least, and probably anecdotally more than that if you've got a good going recognised epidural dural puncture, will develop a headache, and it's a very specific type of headache. It's postural, gets worse when they stand up and walk about, gets better when they lie down. Less common is nerve damage, either from the needle or the little plastic tube going in, which temporary nerve damage is where they might perhaps get a prolonged patch of numbness in a bit of their leg for a few days, about 1 in 1,000. Any permanent injury, though, is 1 in 13,000, so anything more prolonged or permanent. And the much rarer stuff, getting an epidural abscess, an infection around the epidural nerves or the spinal cord, is which is quite serious, obviously. It's 1 in 50,000, but we're fastidious about our aseptic technique, but it can technically happen, and causing bleeding, which could lead to severe neurological damage, requiring surgical intervention or other. That's rare, so that's less than 1 in 100,000. causing a total epidural block, so that's where the anaesthetic goes right up to the brain in the epidural space and the patient passes out, is also very rare, though we've all probably seen it or something near to a total epidural block in our career. So it's quoted as 1 in 100,000. And any severe injury, including paralysis, is rare as hen's teeth, 1 in 250,000. And actually, that's quoting rates around all epidural insertions, so not just obstetric anaesthetics. So it's probably less common in pregnant women. But so something severely, normally badly gone wrong if a patient ends up paralysed. So all the women or their mothers or their grandmothers always seem to have the story about the person who can't walk after an epidural ever, but it is a very rare risk. So nice busy slide here with lots of issues related to epidural side effects and complications, which I'm not going to go to too much in depth, but you can pause it here and just have a little look and note some of these. Some we've discussed already and some we're just going to come on to discuss. Just of note, local anaesthetic toxicity. So that's where the anaesthetic, the epidural anaesthetic is going intravenously where it shouldn't have done. So again, you should get some of that training later on in sort of your intrapartum emergency kind of scenarios and prompt days kind of thing about that in terms of management. But if it is going intravenously, you might get a woman with cardiovascular collapse. You might just feel odd, might get tingling around her lips or tongue, changes in her hearing, and so that's that's the local anaesthetic going where it shouldn't. The opioid in the epidural, I say it's fairly weak. The itchiness we mentioned earlier, that can be profound. So the pruritus. We talked about dural tap, and we're going to come on to talk about that and post-dural puncture headache. And on the other stuff, positioning the patient with the epidural with the epidural can increase the risk of aortic caval compression. So that could affect one's BP and the baby's happiness. Shivering normally happens with this when we put strong stuff in the epidural. When we take them to the theatre and top them up for a section, we tend to warn them that the stronger stuff tends to cause more likely of them shivering, shaking a little bit in their upper limbs, especially. You can get a fever with an epidural being in situ, though it normally does not cause the kind of temperature that would make you to be confused with like a sepsis. So they normally get a low grade temperature. And I won't go into the mechanisms why shivering and temperature happens with an epidural, but it's all very clever and involves the brain misinterpreting signals and thermoregulation. Obviously, there's a slight increased risk of longer second stage with an epidural and needing assisting delivery. And so there's all these various things that you'll sort of learn in your career and on the job that epidurals can cause, but they're generally, let's say, fairly safe things. So again, just to summarise post-dural puncture headache, so it's characteristically postural. So one will complain of a headache on sitting up or and worse on standing or walking about, and gets better when they lie down. And if you think of the spinal fluid like a column of fluid bathing the spinal cord and brain, so where there's a spinal fluid leak caused, that pressure in that spinal fluid is reduced. So when you stand up, the pressure in the spinal fluid, which is already reduced, is assisted by gravity. So the pressure of the spinal fluid around the brain drops even further, and it causes this headache. And the headache's actually caused by vasodilatation of the blood vessels around the brain in response to low spinal fluid pressure, which is why things like caffeine often help, because it's a neurovasoconstrictor, so it counteracts the dilatation of those blood vessels around the brain. So we recommend some coffee as part of our conservative treatment, as well as simple analgesia, keeping the patient well hydrated, because if you keep them generally well hydrated. It keeps the CSF well hydrated to reduce the pain. The headache is, as well as postural, it's normal. Comes sort of the frontal region to the occipital, and sometimes they get pain down the neck. In fact, quite commonly, but shouldn't be particularly stiff. They get mild photophobia, but not normally severe photophobia, and they might feel a little bit queasy, but it's not normally that significant nausea and vomiting. So, how do we treat it if it doesn't get better by itself? We normally wait at least over 24 hours since the initial dural tap or onset of headache before we do it, to give it a chance to work, and also the evidence shows that's when you should do it. So we can do something called an epidural blood patch, which is basically doing another epidural in a very sterile environment, and we go into the epidural space near to where we think we've made the hole, and then we take some blood sterilely, and then we put about 20 mils of blood into the epidural space, and the blood clots and also causes a degree of inflammatory response. And the idea that that clot and the inflammation will close and keep the hole closed and stop the spinal fluid leak, and then things should get better, and normally fairly quickly. So epidural management, just some points to note. It's one-to-one midwifery care is the gold standard. It should, if a lady's got an epidural, they really need a close eye kept on them. They should have a continuous CTG because the epidural can affect baby and baby's happiness, so they should be on CTG monitoring, ideally prior to epidural insertion. As I mentioned earlier, IV access, large bore cannula, ideally not in the ACF, but more in the hand or wrist, because you're likely to be running fluids and syntocin on a lot of the time, and actually, so every time they bend their arm, we're going to get problems with that. So ideally, hand or wrist for the IV access. If you're struggling, perhaps ask the anaesthetist or an obstetrician. Because we starve them with an epidural, because with an epidural, there's more chance of them going to theatre. Any chance of them going to theatre, there's an increased risk of needing a general anaesthetic, so we want an empty stomach. So we don't let them eat after with an epidural. They can have also isotonic fluids, and we give them either ranitidine, or ranitidine is a bit off the menu at the moment with some concern. So Southmead, we're giving them a metrazole, 40 milligrams every 12 hourly, but we used to give 150 milligrams every 6 hours, just as stomach protection, to reduce the stomach acid whilst they're starved. So with the PCAs, you want to do blood pressure once established at least every hour, and block assessment ideally every hour with the ethyl chloride spray. Always gets a little bit tricky, especially towards the end of labour, to keep on top of these things, but they are quite important for the anaesthetist if they need to top patients up in theatre. It's good for us to know where the block's been in the last hour or so, and how much, how often and how recently they press the button. Anticipate sending a group and save when they've got an epidural and a full blood count. IV fluids, as we said, unless they're fluid restricted, say we put an epidural, partly because of severe PET. It's rare that we don't run some sort of fluid, even if it's through a metered pump with an epidural. If they have had a dural puncture, the anaesthetist should do all the top-ups. They should certainly be anaesthetic led, but effectively we will do all the top-ups, because what we'll tend to do is leave the epidural catheter in the spinal fluid canal. They'll just need very little boluses every hour to 2 hours, but we should be doing them. It shouldn't be up to midwives, and we don't connect them up to the PCA pump. So as we say, it's important to monitor the block level ahead of possible needing a strong top-up in theatre. Keep an eye on your IV access, check it's working. For theatre, if you need to take a patient to theatre and the anaesthetist hasn't come in and capped it off themselves, do try to leave that round filter thing when you detach the epidural from the pump. Leave the filter thing on, because that's the sterile filter air filter and its potential infection risk by removing that. As part of epidural management, I think everywhere now pretty much puts in a urinary catheter once an epidural is established and the patient is comfortable, because we have had episodes in the past where even if the woman was able to wee, they don't wee very well, so they don't void properly, and they don't have the same awareness. So we don't want them to have bladder distension and damage. And also, a nice empty bladder with a catheter does make more room for baby's head. Timings of putting in the epidural. Best analgesia is normally once they've in some form of established labour, though we do put them in at patient request at any time of labour and sometimes in latent phase. Again, it's a dialogue between you, the patient, and the anaesthetist, and possibly the obstetricians as to when it's a good idea to put in. But generally, one in terms of managing to assess how well the epidural is, we need to see some sort of contractions. Often also, if you put them in quite early when they're not really contracting, when you need them and they are contracting, often the epidural is more likely to fail. On the other hand, if they're a large lady or particularly anxious, often trying to wait until they are contracting like the clappers and actually getting an epidural in there is very difficult. So it's all about timing, and it will vary from patient to patient. So it's a dialogue that needs to be had about when it's best to do it. But they generally work best when the patient is in some form of established labour, and they'll notice the benefit, and you can assess the benefit more easily. If the epidural is not brilliant, do consider the baby position. So are they OP or OT? There are stronger stuff we can do. There's repositioning the patient, and obviously then if it's still not perfect, you can either recite the epidural, or the woman's happy that to see how it goes. And if baby's head rotates, and then you get a nice epidural with no problems again. The anaesthetist should always initially revisit after the initial insertion, and they should always liaise with you and review the patient if the block is inadequate. Just so you know, there's always sometimes talk about a mobile epidural. I've never seen one. I've seen one attempted. It's not a great idea. So as far as I know, unless someone can enlighten me, I wouldn't think there's anything safe that's called a mobile epidural in labour, because even if the lady feels fairly good strength in her legs, actually balance and proprioception, so the ability to know where to put her feet to safely mobilise, is unlikely and potentially dangerous. One, the epidural could be dislodged, and two, that woman could actually have a fall and cause injury to herself. So not a great idea, this thing called a mobile epidural. So when women have epidurals, it's good to counsel them that they will basically be on the bed, but they will be able to move around the bed, and but mobilising, not a great idea. Anaesthetic spread is affected by gravity, so if the patient's on their left side for a long time, they will tend to get numb just on the left side. However, if you've got an epidural where they've got a little area on their right side that's not great, you could try and consider putting them on their right side and letting gravity spread the anaesthetic to that side in order to improve the block. So I think it's important to recognise that women's top-up needs will vary during labour and from patient to patient. Every patient is different, and their epidural demands in terms of how much anaesthetic, how often with an epidural will vary, and it will vary at different stages during their labour depending on what's happening with their contractions and position of baby. I'd always say beware of the sleeping patient not pressing the buttons. It's the patient that's normally had the epidural put in fairly early on, possibly more like latent phase of labour. Say a primate that's 1 to 2 centimetres. They are in pain. The anaesthetist puts the epidural in. They get very comfy. They go off to sleep. But they're the ones that will, and then the syntocinolone's running, and then when the syntocinolone kicks in, and they're really contracting, they might try and hang on a bit and not press the button because it's not that bad. But often they fall behind on their epidural dose, and then you often find that then they press the button and it's got really bad because they're suddenly contracting properly and really strongly, and they press the button, but they're not achieving the block height that they need with the epidural, and it's a real game of catch up that you're losing. So often the anaesthetist has to come back and try and bolus quite a lot to get back on top of things. So I think when you're managing one of these, any patient, I always, personally, I always remind them, well, don't wait till things get really bad. Anticipate, press the button ahead. It's a safe thing, but then they're more likely to stay on top of their pain, and then you're not going to suddenly have a patient who was nice and comfortable and then in real distress. Tend to, when they get to fully, we tend to give passive descent 1 to 2 hours when they've got an epidural in, just to, because to improve the chances that they're being able to push the baby out. But that's if all other factors are good, obviously. If there's problems with the CTG or or other reasons you want to get them pushing straight away, then you'll just have to. But generally, in straightforward patients with a happy CTG, if they get to fully, try and give them a bit of time for passive descent of baby's head to increase their chances of vaginal delivery. So after they've delivered, it's important to remember to remove the epidural catheter. Don't take it out until they've had a placenta as well. So after delivery of baby and placenta, where you don't think they've got a potential tear that will need suturing in theatre, and obviously if they're not having a PPH. So if they're having any of these things, you'll be more interested in that than removing the epidural anyway. But do wait until everything's calmed down before you think about removing the epidural. When you take the epidural out, document that there's a little blue tip at the end of the catheter at the far end. So it's important to say that that's been seen and it's documented. So we know that it's come out intact. And don't give the Clexane until at least 4 hours after removal. And so it's important to document the time and to remember to take the epidural out before they go to the patient ward, because there have been instances, I remember, where they've gone down to the ward with an epidural in, then had their Clexane, and then you have to wait 12 hours till you can safely take the epidural out after the Clexane. So what you want is epidural out before postnatal ward, and then no Clexane until at least 4 hours until after removal, because there is that potential risk of hematoma if you do it too soon or with Clexane on board. If they have a very prolonged block, say a prolonged motor block, I mean, everyone's different, but if you're concerned that it's taking a long time for their legs to come back or whatever, do again ask the anaesthetist to review. Just another word about the patient-controlled analgesia, so remifentanil. So it's an alternative to PCA where it's contraindicated, as we discussed earlier. So it's a very potent morphine-like drug with a very short half-life, and it wears off like within 5-10 minutes. There's a risk of respiratory depression, so they should have some nasal oxygen on. Again, same as an epidural, it requires constant one-to-one midwifery care, and including a PCA chart for documenting your obs, etc. It can be difficult for them to time the boluses with the contractions, but some will do really well with it, some not so well. And it's not available everywhere, so not everywhere uses it. And it's probably not used in that many patients, to be fair, but it is an option, like all of these pain relief issues that we discussed earlier. So a little bit about spinal anaesthesia. So this is where we put some anaesthetic mix injected into the cerebral spinal fluid. This is the thing we can do for routine cesarean sections, and it spreads in the spinal fluid. There's the common doses of what we put for a spinal block. So it's a little bit stronger, and it's got some diamorphine in or some fentanyl to prolong the block and improve it. But you notice compared with an epidural volume, it's significantly smaller dose, because unlike an epidural where there's nothing in the epidural space, we're putting some anaesthetic into a column of spinal fluid, and we're getting it to spread through the spinal fluid. And it's actually, once it spreads, we don't need as much volume to achieve our high block. So we're putting these in normally. Say for a cesarean, we want to block up to T4. So it's less than 3 mils we put in to achieve that. So it's not very much. And we choose what we stick in the spinal anaesthetic based on urgency of the cesarean, speed of mix. So mix it. If we put diamorphine in the spine, we have to mix up the diamorphine and dilute that down, and it takes a little bit longer than just drawing up some fentanyl with the bupivacaine. So it's quicker for us to draw up and inject, and we choose what we might want to do a manual removal under a spinal block or a third-degree tear, and we won't need as high a block for that, so we won't need so much volume, and often it's a shorter thing, so we won't perhaps put the fentanyl or diamorphine down. So the anaesthetist will choose our spinal anaesthetic mix depending on what we're doing. So the two that are illustrated there are mostly for cesarean sections. So as it says at the bottom, we aim for a block level of about T3-4 for cesarean, T7-8 for a manual removal or an EUA for, say, a PPH, and T9-10. So we need quite a low block for a fourth degree tear. You could probably argue that we need slightly even lower than that because we basically just need a perineal block. So spinal anaesthesia advantage, it's more predictable than an epidural, which is why we use it routinely as a first line in a non-labouring woman for a cesarean or someone who hasn't got an epidural. It's a single shot, so once you put that spinal anaesthetic in, that's it, that's your lot. You can't top it up because there's nothing staying in. It's one-off injection. There's more motor blockade normally, so it's very good for stuff in theatre. It's less suitable for labour. Though sometimes we do CSEs, which are combined spinal epidurals. So if we've got a woman in real extremis in a labor room, we might put in a low dose spinal block to get her comfy and then put the epidural in. And then the spinal block in the room will keep her comfy for an hour or two, and then we get the epidural to take over. It's a smaller needle, so it's 25 gauge, so it's tiny compared with an epidural needle. So although we're deliberately making a hole in the spinal fluid canal with it, it's a tiny needle, so it's less likely to cause a hole that won't close and leak and cause a headache. So hence the post-dural puncture headache rate, so the PDPH rate is 1 in 500. So although we're deliberately making a little hole in the spinal fluid canal, it's with a tiny needle, and so less likely of causing a headache. Spinal anaesthetic does tend to give more profound hypotension or bradycardia. It's just the level it blocks the spinal cord nerves. And we normally, in say a cesarean, we will run some vasopressors, so drugs that can contract the blood vessels to improve blood pressure. So we normally run infusions after we've put a spinal block in for, say, a cesarean to maintain blood pressure. High spinal is more likely than a high epidural, just because the anaesthetic can spread less predictably through the spinal fluid, so it can get up towards the brain, which is less likely than with an epidural. So what follows is just a couple of videos now. So the first video is going to show you a spinal anaesthetic being inserted, and the second one's called the glass spine, which is a scientist, very clever scientist, proper scientist, showing you how when the spinal anaesthetic goes in to a patient's spine, how it spreads through the spinal fluid. It's very exciting and shows you how quickly it does actually move usually and how it gets affected by gravity. So I'll see you after these couple of vids.
Ladies and gentlemen, let me introduce the glass spine. The first description of a glass spine similar to this one was made in 1907 in the British Medical Journal by Arthur Barker, who was Professor of Surgery at University College Hospital in London. This one has been in the Nuffield Department of Anaesthetics here since the early 1950s, where several photographs of it appeared in Professor McIntosh's famous monograph, Lumbar Puncture and Spinal Analgesia. It's essentially a glass tube, curved in the same way as the vertebral column and therefore the dural sac and subarachnoid space, with a small cervical convexity anteriorly, a larger thoracic concavity anteriorly, another small lumbar convexity anteriorly, and the dural sac ends here at S2. The glass spine has a rubber injection port here in the mid-lumbar region, and this rather curious structure at the head end is an expansion chamber. The reason for this is that glass, unlike the dural sac, is completely rigid, and it would be impossible to even inject 1 or 2 mils of solution into the glass spine without there being some way for this fluid to escape from it. There are other ways in which the glass spine differs from the dural sac. In particular, there is no spinal cord and no nerve roots in the glass spine. The glass spine is filled with normal saline, which has got a density very similar to that of cerebrospinal fluid. I think it's appropriate here to talk about specific gravity and baricity. Much confusion has arisen over the years by using the term specific gravity to describe fluids injected into the subarachnoid space. Specific gravity is a term which requires that the temperature of both the injected solution and the liquid into which it's being injected are defined. Baricity is a much more useful term because baricity refers to the density of the solution used compared with that of cerebrospinal fluid at body temperature. And the term hyperbaric is used for a solution which is more dense or heavier than cerebrospinal fluid, isobaric for a fluid which has got the same density as cerebrospinal fluid, and hypobaric if it is lighter. For the first part of the demonstration, I'm going to inject a solution made hyperbaric with dextrose and stained with waxylene rhodamine. And on this occasion, the patient is lying on her side. As I inject the solution, it cuts across the subarachnoid space and therefore the nerves of the cauda equina, and it moves a little upwards and downwards, cephalad and caudad in the subarachnoid space. We finish the injection, take the needle out, and turn the patient onto her back. And the heavy solution runs in both directions, caudad and cephalad, in the subarachnoid space. What runs caudad is achieving nothing further in the way of a nerve block because the cauda equina has been cut off. It is the solution which runs in the cephalad end which is of interest. It runs very quickly, and I've only taken about 12 seconds since I injected the solution, and it is already slowing down and indeed stopping in the what would represent the mid-thoracic region. Even if the patient is tipped head down, and this would be quite a steep head down tilt on a bed or table, the solution will only run another segment or two before it begins to slow down again. If, on the other hand, and there is enough dye to show this, after the injection the patient had been left on her side, but even a little bit head down, there is nothing to stop the solution running higher into the upper thoracic, cervical, and indeed even the intracranial subarachnoid space. For the next part of the demonstration, I'm going to inject a hyperbaric solution with the patient in the sitting position. And if you can inject very slowly, which sometimes is difficult, the local anesthetic may just trickle down into the lowest sacral segments in the chorda equina. And this gives what is known as a saddle block spinal. More commonly and perhaps more usefully, if you inject just slightly quicker, the local anesthetic goes straight across the chorda equina and cuts the nerves off from that level downwards, which would be about L2 or thereabouts. But the local anesthetic moves very little up in the subarachnoid space, perhaps a segment or two. For this next part of the demonstration, I'm going to inject a hyperbaric solution with the patient sitting up and then lying them down. This is a popular method of anesthetizing patients, even for quite high operations in the abdomen. So once again, as we inject the solution, it cuts across the nerve roots in the chorda equina. And at this point, most of it goes downwards in the subarachnoid space. So we finish the injection and then take the needle out and turn the patient onto her back. This would be wedged, of course, if it was a caesarean section. And once again, the local anesthetic runs both ways in the subarachnoid space. I think it's worth noticing that the dye in the caudal end of the sac here is quite intense, and this is because an unpredictably high proportion of the local anesthetic gets trapped in the caudad part of the lumbar convexity. But in the thoracic end, it once again runs down to the lower part of the thoracic concavity. But in this case, it is just possible that the spread of dye you can see is less intense. So although the block goes high enough, it may be a rather less intense block and may last less time. This time I'm going to inject an isobaric solution, which on this occasion is stained with methylene blue, with the patient again lying down and then turned onto her back. So as we start the injection, cuts across the chorda equina again, but being an isobaric solution, it doesn't favor the dependent side. Moves upwards and downwards slightly, cephalad and caudad in the subarachnoid space. Take the needle out, turn the patient onto her back, and this time the dye makes no effort to run either down into the caudal or the cephalad end of the subarachnoid space. From a nerve blocking point of view, the lack of dye and therefore local anesthetic in the caudal end of the sac doesn't matter, because as usual the local anesthetic has cut across the chorda equina. This sort of block is good for operations in the region of the hip and the lower abdomen because it's very easy to block up to about L1 or T12, but it can be very difficult to get these blocks to go higher. The reason for that is that not having gravity affecting these isobaric solutions, they're affected more but unpredictably by other factors over which we've got very little control. The most obvious one perhaps is temperature. These solutions after injection warm up to body temperature and may become marginally hypobaric, and in these circumstances, if the patient is sat up, they may rise in the subarachnoid space. Other factors which may affect the spread of these isobaric solutions are internal barbotage as the nerve roots in the subarachnoid space stir the local anesthetic up. And certainly in obstetric patients, aortocaval occlusion causing congestion of the epidural veins may squeeze the dural sac and make the block go higher. Other unpredictable factors might be coughing and straining, and because of that, these solutions occasionally go disconcertingly and unexpectedly high. We put the patient back on the side again, and the solution makes no effort to move, it just hangs there. It's now possible to demonstrate the effect of barbotage. This was used more in former years to try and increase the spread of solution. And this involved aspirating the cerebrospinal fluid after the injection and injecting again. And you can see that it has some small effect in stirring the dye up. This is not considered a useful technique in modern times because spinal needles nowadays are such small needles that there is very little reliable effect of barbotage. But spinal needles many years ago were very large, and barbotage was often included as part of the technique. Now, several minutes later, whichever position the spine is put in, the dye just hangs there and makes little effort to move. For the final bit of this demonstration, I would like to use the glass spine to show a problem which may arise when local anesthetic solutions are injected through a catheter into the subarachnoid space. But first, a few words of explanation. In the late 1980s and beginning of 1990s, there was a flurry of enthusiasm for using continuous spinal anesthesia. And to this end, a number of manufacturers, so that the incidence of headache could be reduced by using smaller needles, produced small subarachnoid catheters. Most of these were 28 gauge, which would go through a 22 or 23 gauge spinal needle, but one was a 32 gauge microspinal catheter, which would go through a 26 gauge needle. But before these catheters had been in use for very long, several cases of cauda equina syndrome were reported to the FDA in America. That's the Food and Drug Administration. And I'm going to show you what may happen. I have here a 28 gauge catheter, and I'm going to use a 1 ml syringe for the injection because you need that sort of pressure to get the local anesthetic solution down the catheter. It was customary in these cases, unlike most spinal cases when using a hyperbaric solution, to lay the patient in the supine position before the injection. As you remember from earlier in the demonstration, usually except for a saddle block spinal, the patient is either lying in the lateral position and turned into the supine position, or sitting up and then laying down. But with these continuous spinal catheters, the tendency was to position the patient in the supine position and then start the injection. So in this case, I've got this 28 gauge catheter, and you will see the hyperbaric solution traveling down the tube and then appearing at the tip of the catheter, which is passed caudally in the subarachnoid space. And the dye, in other words, the local anesthetic solution, trickles down very much in the way of a saddle block spinal to affect only the lowest sacral segments of the spinal cord. And as we continue the injection, a higher and higher concentration of dye appears in the sacral segments, but still no block appearing higher than the tip of the catheter, which in this case would be in the L3, L4 region, and therefore this would be quite useless even for an operation as low as the groin, for say a saphenous vein or an inguinal hernia operation. And still none of the local anesthetic has spread over the apex of the lumbar curve. The tendency then was to inject more solution. And I've got another syringe here, and I'm going to inject more dye, more local anaesthetic, and it follows the same track down into the caudal end of the sac. And this is typically what happened in these cases, that a larger amount of local anaesthetic was injected than would usually have been given by a single shot injection. And now at long last, the dye is beginning to spill over the curve and would have produced a block which would have been high enough for an operation in the sort of lower abdominal region. But the expense of a very high concentration of dye and therefore local anaesthetic and dextrose, which would be hypertonic, in the caudal end of the dural sac. And it was thought that this was the cause of the nerve damage, that these high concentrations of local anaesthetic and possibly dextrose were neurotoxic. Because of this, the FDA removed all small bore catheters from the market, and the situation nearly 4 years later remains the same in the United States. But this ban does not apply in all countries of the world, although some countries did follow the lead of the United States of America. Anesthesiologists investigating the cause of the cauda equina syndrome made various recommendations, including repositioning the patient if the desired effect was not obtained with a reasonable dose of local anaesthetic, stopping at a maximum, and an alternative was perhaps to change the porosity. And I've got once again the isobaric solution here, and I will inject this, and we'll see the difference in effect between that and the hyperbaric solution. Starting the injection, you just see the blue dye beginning to come down the tube, running into the subarachnoid space again. But you can already see that it's not heading so briskly and so fast down into the lowest sacral segments. So we continue the injection again, like isobaric solutions. Under other circumstances, the block does not spread very far, it's not affected by gravity. And while it's making quite a high concentration around the tip of the catheter, this does not run down into the lowest sacral segments. So it would seem in any case that it's probably more sensible and safer to use isobaric solutions for continuous spinal anesthesia. Even now, lowest sacral segments with no dye present there at all, therefore no local anaesthetic, no high concentration of dextrose. In concluding this demonstration, I should say that although it is nearly 100 years since Professor Arthur Barker first described his glass spine model, you have seen that it remains a unique
So we're just going to briefly talk about general anaesthesia in obstetric patients. So again, going back a few years at Southmead, these are pretty typical of national figures. So about 1% of our elective cesareans and 5% of our emergencies with general anaesthetic. And probably the 5% strikes me as quite high. We increasingly try to avoid, we always try and avoid general anaesthetic. But there's certain circumstances in elective sections where regional is inappropriate or dangerous, and in emergency zones where it's literally maternal or baby's life is at risk and we have to do a general anaesthetic. Increasingly with AIP, abnormal invasive placenta cesareans, GA will be part of that because I think there'll be a planned hysterectomy, which is hard to do under just a regional anaesthetic. Overall, general anaesthetic is less safe for mum than a regional anaesthetic. And it's indicated to say when there's no time to do a regional anaesthetic because of fetal distress, or where it's contraindicated or considered unwise. So why is a general anaesthetic a little bit more of an issue in the third trimester obstetric patient? So they have physiological changes that we have to take into account, and I'm not going to go into all of this now, but they have a different, but as you'll know as midwives, they have changes in the cardiovascular system, respiratory system, and upper GI tract that mean that they're potentially higher risk for general anaesthetic. They've got lower lung capacity, they've got functional hiatus hernia when they're fully pregnant. They also have anatomical changes occur in their airway and spine that can make intubation in general anaesthetic more challenging. We always obviously have to consider pharmacological issues in terms of general anaesthetic drugs that might affect mum or baby. Less so endocrine stuff, but that's a consideration. And obviously, we always, going back to talking about clexane and thromboprophylaxis, PET therapy, there's all these issues around deciding to do a general anaesthetic and when we should do it. It's just important to recognise that even when mum is no longer pregnant, the physiological and anatomical changes, especially when they're obviously third trimester, we still consider them as anaesthetist pregnant until at least 48 hours postnatally. So in terms of the challenge of a general anaesthetic versus a regional anaesthetic, we and starvation, etc., we consider them a pregnant patient for 2 days after. They are more likely in terms of airway to be more difficult intubation than the general population. And obviously we're likely to sometimes be doing general anaesthetics in emergency situations. So that's potentially a difficult airway. And then the fact that they're pregnant makes it potentially even more risky. So we always try and avoid a GA. Alluding again to their respiratory changes, they have reduced FRC, so functional residual capacity to residual volume. So basically, they've got a big bump pressing on their lungs. They've got less capacity in their lungs and less reserve, and they're using oxygen more quickly. So they desaturate if they're not breathing quickly. So if we can't ventilate them quickly, they're going to go blue more quickly, by and large. So again, as I mentioned, with their upper GI tract, they've effectively got a hiatus hernia, they're higher risk of stomach contents coming up from through their esophagus and into their lungs, which cause devastating pneumonitis or aspiration pneumonia, and that's actually the leading cause of maternal death with GA at the moment. And obviously, we don't tend to have them starved when they're a labour ward patient, or we can't guarantee that they won't have eaten within 6 hours, and we're not so sure that 6 hours is enough starvation for a pregnant woman. We query about reduced gastric emptying rate whilst they're in labour as well, but there's not a huge amount of evidence actually these days that labour reduces their rate of gastric emptying, but there's increased fundal pressure when they're supine, and they query that they have reduced motility in the small intestine. So there's more chance of stuff in the stomach perhaps, and if there's stuff in the stomach with a general anaesthetic, there's more risk of aspiration, and aspiration pneumonia or pneumonitis is quite severe, and it still carries about 50% mortality. So there's all your preparations for general anaesthetic. So yes, we want to give them stomach protection, ranitidine or omeprazole. Very important that we give them sodium citrate before we put them off to sleep. So that's basically an antacid little fluid. So it won't stop them aspirating, but it will neutralise the stomach acid or the stuff in the stomach. So it's less likely to cause irritation and damage should it come up and go into the lungs. We do left lateral tilt, which we do for everyone in theatre, but it's particularly important in general anaesthesia. We do something called a rapid sequence induction. So we pre-oxygenate the patient. We put cricoid pressure on, a little pressure on the neck to try and reduce the chances of stuff coming up from their esophagus and into their lungs. It's important because we're going to put the patient off to sleep. It's going to affect baby as well. So we want the surgical team, we want the pediatric neonatal team ready. We want basically the skin prepped on the tummy. So we want to know that when we put the patient to sleep, there's as little time as possible between us putting the patient to sleep and baby being delivered. So there's little effect to mum and baby. It's important when you're in theatre with a general anaesthetic that the anaesthetists really need a quiet environment to work in, especially in an emergency general anaesthetic cesarean. We give the nod from the anaesthetic side when we're happy for the obstetricians to actually make the incision. Maternal well-being in these situations is the priority. So we obviously want a healthy baby and a healthy mum, but the priority for us is a healthy baby. There's no point in having, for us, a live baby and a dead mum. Our priority has to be mum's well-being, and by looking after mum well, actually we're looking after baby as well. We're doing the best for baby by looking after mum and keeping her oxygenated and perfused and stuff, because that's helping baby. So we have to concentrate on baby, and if we can't intubate, we have to wake the mum up. It's important for us to do that, even if there's adverse consequences to the baby. We often have to sometimes give morphine-like drugs to obtun. So when laryngoscopy is when we're putting the tube down the lungs, it's very stimulating. It raises the blood pressure. So in certain patients, say with preeclampsia, we might want to give some opiate to reduce that hypertensive effect of putting a tube down in the lungs. So we normally will warn the neonatologist that baby might be a little bit sleepy or respiratory depressed because of those drugs. It's important because of it's quite distressing to watch a general anaesthetic if you're the birthing partner, if it's a loved one. And also it's quite stressful for the team, especially the anaesthetic team, to have a partner present. So as a general rule of thumb, no birthing partner allowed to be present at the induction of a general anaesthetic. But it's important that they get good communication to them outside theatre. Okay, so that's been quite a lot to cover today. And let's just take a few sort of take-home notes in general. So anything to do with anaesthetic risks is always obviously best identified if there's going to be things that are going to affect what we do as anaesthetists. It's nice if we know during the antenatal period. So prior to 36 weeks, we'd like to know about it. So the time they're least likely to hopefully come into labour ward. The worst time for us to know about potential problems or medical issues or maternal concerns that might affect what we do in terms of pain relief and regional anaesthesia, etc. It's best identified when they're not in labour or threatened labour or about to be induced. So we would like to, where possible, speak to them or see them in some point in their antenatal care. So midwives and obstetricians refer to us, and most places will have that liaison between maternity staff and anaesthetists to allow that to be possible. If you're in doubt about a woman in your care regarding pain issues or whether there's going to be issues for their having an anaesthetic or an epidural or spinal, ask one of your senior midwifery colleagues or approach us directly. Just remember, all women in labour may want or require regional anaesthesia, even if that's not part of their birth plan, or may potentially end up having a GA in an emergency situation. And it doesn't mean to be ultra cautious about it, but it's just always to bear that in mind in terms of how we manage women on the labour ward and pre-labour ward. So all women in labour, especially those that are on the delivery suite because of risk factors, have they had a blood count recently? Do they need a group and save? Just always think about these things. Just think, well, what if this patient does end up with problems in theatre? It doesn't mean that there aren't low risk women, that we should medicalise things too much, but we should always consider that. And especially if you identify something that especially if they might want an epidural, particularly, we would want an FBC as baseline. We would probably want a group and save. Okay, but discuss. In our unit, we review all women with a BMI over 40. Where they're larger than that, often in the antenatal clinic, we'll review them antenatally and discuss them with a plan with pain relief and epidurals and stuff. But if they pitch up and their BMI is 40 or above, then we're obliged to do an anaesthetic review when they're in labour or when they're in the unit. We certainly need to know about it. IV access early where appropriate in all these ladies that might have an epidural. And just really emphasize it's large bore cannulation. And it's better than having multiple attempts and using up a lot of veins by failed attempts. If they're known difficult veins or you find that they're difficult, it's best to probably ask us early to have a go ourselves, because it's nicer for the patient, but also we will be happier than being asked to be the fifth person to have a go putting a cannula in when there's no veins left. Just remember, platelet count could be dynamic in PE2 patients. So we tend to want to know it every 4 to 6 hours, because it will affect our decision making on epidurals and spinal blocks. It might prevent a general anaesthetic if they've not had if their PET bloods are off, but it's been a while, and then they suddenly need to go to theatre. The anaesthetist might be siding on the side of wanting to do general anaesthetic in the absence of a recent full blood count. When assessing a patient, think, should I fast them? Should I omit Clexane? Consider where your patient will be going in the process. So, are they going to be heading to theatre? Are they going to want an epidural anyway? So think about these things, and this goes from the antenatal wards right through. So just bear these little factors in mind. It's part of all of the loads of decisions you have to make and advise on, but always try and remember the anaesthetic considerations if you can. Okay, so thank you for listening today. Sorry it's a little bit longer than planned, about an hour and a half this has been. I hope you've been able to skip forward, wind back, and take it at your leisure. Anaesthetists are generally approachable. So if in your practice as students, midwives, whatever, you have further questions, most anaesthetists are quite happy to share their thoughts, wisdom and opinions. So do approach us. Oops.